to hit the record button. Okay, now we're recording. As we know, we talk a lot about hospice care, and it seems that seems to be an area where we're very familiar and have a lot of experience and expertise and know the lingo. But when it comes to palliative care, it seems that there's not as much information about it. So hopefully the plan today, the goal for today is that Fran is going to educate us more about palliative care, how we could utilize this for our clients potentially, how our teams could promote the service, and what it is. So I'm going to turn this over to Fran, and thank you very much for presenting this morning, Fran.
Thanks, Adina. Thanks for that intro, and good morning, everybody. You know, it's true what she says. A lot of people really don't know what palliative care is. Docs don't know what it is. Nurses don't know what it is. Patients and families don't know what it is. You know, they think it's the same as hospice. They think it has something to do with end of life. They think a person must be dying if you're recommending that, and then they don't want it. You know, so a lot of nurses say, well, I spoke to the family and they didn't want it. I'm like, well, what is it that they don't want? They don't even know what it is that they don't want. So my goal today is to kind of define what it is and who's eligible and how you can utilize palliative care in the home environment. So palliative care is for people that are living with serious illnesses, and it focuses on quality of life. You know, the relief of pain, the relief of other symptoms, relieving stress, and working with families is one of the key things that we try to achieve with palliative care. It's not just that the patient is our patient, the family is our patient. So we're looking not only at, you know, patient goals, but we're really looking at family goals as well. You know, we have a lot more people today living with serious illness, and they're living for decades. And we do a really good job at taking care of their cancer and taking care of their hypertension and their CHF. But what we don't do a good job of is taking care of the person that has that disease and the stress and the anxiety and the symptoms that come along with it. So palliative care can be provided wherever the patient needs help, whether it's at home, whether it's in the hospital, whether it's in the nursing home, whether it's in the doctor's office. And there's really a big push to get more education out there about palliative care. So I'm thrilled to be here today. So this first slide looks at the difference between hospice and palliative care. Hospice, as you know, is a Medicare benefit, so Medicare pays for that. In order to be eligible for hospice, you have to be in your last 6 months of life if your disease runs its normal trajectory. The problem is that 75% of the time, we are incorrect when we tell people how long they have to live. And then if you tell people that they have 6 months and they live a year, well, then they're never going to die, and then they never want to hear, you know, about end of life because they beat the odds. They were told they had 6 months and they've been living 2 years, so we don't need to talk about end of life here because we beat the odds. In order to be eligible for hospice, as you know, you need to meet criteria, and that criteria is getting stricter and stricter because Medicare is spending a lot of money on hospice care. So they want to make sure that people are eligible. We used to have a diagnosis of failure to thrive for hospice, which everybody fell into. That was just losing weight, but now they took that away because too many people were using that diagnosis and, you know, were not necessarily eligible. Hospice wants to make sure that it's not custodial care that hospice is providing, but that it's actually hospice care. When people are on hospice, they've chosen not to have any more active treatment, no chemo, no TPN, no surgery, no radiation. Hospice is provided by a team. You guys are familiar with that. It can be done in any setting. And again, the family and the patient are the focus. So palliative care can occur at any phase.
Fran, I'm just going to interrupt for a second.
Yeah.
We could see your screen. So if you can go to the next slide so we can follow along with you, that would be great.
I'm on my slide says difference between hospice and palliative care.
Oh, because we just see that first slide. So the community-based palliative care.
Did it move?
No, it didn't move. Okay.
How do I make it move? Can you move it from your end?
I just have to make myself the presenter. Okay, so keep going, and I'll take care of that.
All right. So it can occur at so palliative care can happen at any phase in an illness. Now, many institutions are starting palliative care right when the patient's diagnosed. So they meet with the oncology team and they meet with the palliative care team. Palliative care is also provided by a team, a nurse practitioner, sometimes there's a chaplain. We work with the social worker, with the physical therapist, with the speech therapist, with the dietitian, because we're trying to provide a holistic care. So the patient can still be getting active treatment. It can also be done in any setting. The patient and family are the focus still, and it's covered by insurance. So when you see a patient for a palliative care visit, you're just billing insurance just like any other consult. Next slide. So specifically, palliative care is excellent evidence-based medical treatment. It's vigorous care of pain and symptom management, and it's care that patients want at the same time that they're doing their treatment, their chemo, their radiation. Palliative care is not giving up, so patients say to me, so we're not going to do anything? No, what we're going to do is we're going to, focus tremendously on quality of life and making sure that the patient's comfortable and that they don't have anxiety and that they're not short of breath and that every day can be the best day it can be. And that's the focus of palliative care. So we're never doing nothing. We're always doing as much as we can to achieve, whatever it is that patient needs. It's not in place of curative or life-prolonging care. It's in addition to, and it's not the same as hospice. Next slide. So we're past the tipping point. Palliative care is still fairly new. It's only been, really around maybe 20 years or so, but it's becoming an established field. There are more and more hospice teams for palliative care than there were before. I'm going to show you some slides on that in a minute. There's a formal certification process. There is palliative care and hospice certification for nurses' aides, for LPNs, for nurses, for advanced practice nurses, for chaplains, for social workers, and for long-term care administrators. So we're one of the few certifications that has all those levels, and of course for physicians. There's also now hospital accreditation. So some hospitals are accredited as Joint Commission accredited palliative care hospitals. There's a rising public and professional awareness. We really want to get more people to understand what it is so they ask for it when they go to the hospital. And there's more training options. We now have palliative care APN programs and palliative care and social work programs and palliative care and chaplaincy programs and more palliative care and residency programs that we ever had before. So we have a lot more evidence-based practice than we did before. There's a lot more policies out there that I'm going to show you in a minute that address palliative care. So we're really past that point of, oh, this is a new thing, oh, what is it? It's really kind of, really out there. So this graph, next slide, just shows you the growth in certified nurses. We've had a 19% growth since 2010. There's over 13,000 certified nurses in the country. The next slide looks at the growth in physicians, which has had tremendous growth. In 2008, there were a little over 1,000 physicians that were certified in palliative care, and in 2013, there's 6,517, which still is not a lot when you think about across the country. But again, remember, this is a fairly new field, and this kind of shows you that. In 2008, which was really only 8 years ago, there was only 1,000, and now we have 6,500. Next slide looks at the hospice, the palliative care programs in hospitals. The red line is the percentage of hospitals, and the blue line is the number of hospitals. So you can see about 72% of hospitals have palliative care programs. And I'll tell you, working in many hospitals, the programs look different in all the hospitals. You can't say that if you're looking at 5 different hospitals, their palliative care programs are the same. Some of them are real robust. They have a team of physicians, doctors, chaplains, social workers, and some of them, just have maybe one doc or one advanced practice nurse. The next slide looks at what payers are thinking. A lot of the insurance companies, this is a big hot topic for them too, because they don't want to spend all this money on people going to the hospital. When you look at the finances, and I think we're going to do another program down the road that just looks at the business aspect of end of life and how much things cost. But I'll just say now that these insurance companies are spending a lot of money on people in the last 6 months to a year of their life, and they're trying to figure out whether that's necessary or not. And palliative care is something that can help fix that problem. This is just a graph of the different states around the country. These numbers look at the amount of consults that patients get in the last 6 months of life. So the legend on the side shows you that New Jersey is right up there, and so is Florida as being the top amount of consults in the last 6 months of life. We generally have 10 consultants seeing a patient in the 6 months before they die, which if we're focusing on dying and end-of-life care, we really don't need 10 different consultants on board. The next slide looks at what are people dying from. 7 out of 10 Americans are dying from a chronic disease, with 9 out of 10 of them being one of the following. And this is no surprise to us. I'm sure most of the patients you're seeing at home have these diagnoses. It's CHF, chronic lung disease, cancer, coronary artery disease, renal failure, liver disease, peripheral vascular disease, and dementia. So 9 out of 10 people are dying from these diseases. So if we know these are the diseases that people are dying from, and especially people that have a multiple amount of these diseases, 2 or 3 of these diseases, we can kind of project that if we're admitting a patient and they have multiple, diseases of these, we know that there's a good likelihood that they're going to die from it. The next slide, I really love this picture because this is so true. I've been an ICU nurse for, a good part of my career, and this is the tragic situation of what people look like in the ICU. They have all of this, they're connected to all of these tubes, and we're spending all of this money, and they end up dying in the end anyway. You've devastated the family financially, you've devastated them emotionally. Now they're looking at studies that there's post-traumatic stress to families who family members have died in the ICU because of all of the things that we do to them, and palliative care, eliminates that. The next slide looks at the latest IOM study, which is Dying in America, Improving Quality and Honoring Individual Preferences Near the End of Life. You can go, the website is there, you can go to that website and they'll actually send you a PDF of this. It's not super long. It's maybe like 10 pages, and it goes over the recommendations that they made. This just came out in 2014, so this is the newest one, and they made 5 specific recommendations. And those recommendations are that palliative care should be a standard of practice everywhere, whether the patient's at home, whether they're in a nursing home, whether they're coming to a doctor's office, or whether they're in the hospital. Palliative care should be a standard. There should be training, required universal training, and certification in palliative care. There should be policies and payments to support the medical and social needs. So all the insurance companies should be on board, understanding the importance of paying for palliative care. And there needs to be public education and engagement so that our lay people out there know exactly what it is. And there's also a link there for you with more information. So some facts on palliative care. Next slide. 90% of deaths are predictable. 80% of deaths occur in people over 65. 70 to 80% of people want to die at home, but that's not really where they're dying. 60% of hospice admissions are for non-cancer diagnoses, most of that being dementia, some cardiac, some lung. 40% is for cancer. 40% of families become impoverished as a result of caring for a terminally ill relative. I'm sure many of you have seen the stats on caregivers and how much money caregivers would be paid if they were actually paid for their caregiving. Only 1/3 of people in the United States have an advanced care plan, which is a problem. Significant numbers of people die in moderate to severe pain, which is a problem, because palliative care's focus is symptom management. And the national median hospice length of stay is 21 days. Now, hospice is a 6-month benefit. You're supposed to get it for 6 months. So we should be planning ahead and thinking ahead who of our patients are appropriate for hospice. And that's one of the things that palliative care does, is they help families transition into hospice when the time is right. Every time I meet a family, I say to them, they're not appropriate for hospice now, but when they are, we'll have that discussion, and we'll talk about what that means, so that we've planted the seed. The next slide looks at how people die in this country. There are basically 3 ways people die. This first way here is sudden death. You're walking down the road, you're healthy, you have a massive MI, and you drop dead. You get hit by a car, you have a massive subarachnoid bleed. 10% of people die this way. The next slide looks at the way many other people die. There's a long decline. You know, they get a stroke and then they just decline. They stop eating, they stop walking, they get contractures, they get bed sores, they get pneumonia, and then they die. So we know what's going to happen. We know they're going to die along the way. This is the trajectory that they follow. So you have to figure out at what point during this trajectory do you want to implement palliative care. The next slide looks at another decline that has periodic crises. A lot of the people you care for, you may see this. You're taking care of them, they go to the hospital, they get pneumonia. They come back, they're not as good. 6 months later, they go out to the hospital again, and they get urinary tract infection or sepsis. Then they have a fall. So they have these declines, and then they die. So again, I show these graphs to families all the time because families don't often see what we see, and they don't see the decline. But we know that death is at the end. So the societal impacts to end of life, we know that people are living longer. That's no surprise to anybody now. We hear that all the time. We have families living halfway across the country. So here's, you know, Mrs. Jones, whose daughter is living with her, and says, yeah, we just want to keep mom comfortable. We want a palliative care plan. We want to transition into hospice. And then the daughter from California calls and says, oh, no, no, no. We want to do everything for mom. So that's why we really need to get families on board that are across the country from the get-go so we're all on the same page. People are living longer with chronic illness. You know, a lot of times now, you know, many of us when we were younger, you know, if we're, you know, in the baby boomer age, we lost our grandparents when we were younger. You know, my kids, some of my stepchildren, my daughter-in-law and my son-in-law, they all have 4 grandparents. You know, so a lot of people have not really experienced death until they're late adults. Health professionals are not comfortable talking about death. You know, to go in and say to somebody you're in the dying process is something that people are not comfortable doing. The next slide looks at some of the barriers that we have to quality care at the end of life. People don't acknowledge the limits of medicine. Let's keep doing and doing and doing. When I was at the conference, the palliative care conference in Chicago in March, I met someone who was from another country, and she was saying, you know, in her country, people don't ask for feeding tubes because they know they're not going to get them. They just don't do it. They don't go to the ICU. They don't get put on respirators when they're dying. But we do everything to keep people alive, and we're really just prolonging death. There really isn't enough training for healthcare providers, which is why, you know, we're trying to get the word out. Hospice and palliative care services are poorly understood. Nobody really knows, you know, what they are. People think hospice is 3 days before you die, and they think palliative care is when you're dying and you're not going to do anything. So it's really difficult. You know, we have rules and regulations, hospital rules. You know, I was talking to a nurse yesterday who works in a big hospital that does open heart surgery, and if patients are crashing after open heart surgery, they don't want to call in palliative care because if a patient dies within 30 days of their open heart surgery, it's counted as an operative death, and hospitals don't want that, and therefore they don't want to call palliative care within 30 days after their open heart surgery. So that's the policy and, you know, the politics of palliative care. People are denying death. You know, they don't want to admit that death is coming. MDs, a lot of physicians are resistant to palliative care. They just want to keep doing and doing and doing. A lot of nurses can't really explain it, so patients really don't know what it is because of the lack of education. You know, you may recommend things and the staff doesn't follow through. The families can't make a decision because there's 5 kids and they all can't agree. And there's inconsistent communication because you've got 10 consults on the case. The heart doctor says, oh, the heart looks good. The lung doctor says, oh, the lungs look bad. Next slide. So which patients should you be thinking about that are appropriate for palliative care? Patients with multiple chronic diseases, as we mentioned before, patients with frequent hospitalizations, patients that have significant weight loss or physical decline, patients that have a terminal illness, patients that have been seen by palliative care in the hospital or nursing home and now they're home, families or patients that are saying, I don't know what I should do next, and people that are homebound. So these are all patients that would be appropriate for a palliative care consult. Next slide, general principles of palliative care. The patient and the family is your unit of care. So you're not only looking at the patient, you're looking at what are the family goals. You know, sometimes they say, my daughter's getting married in 6 months. We really want my dad to be able to be at the wedding. So maybe palliative radiation may be something he may need. You know, maybe a little TPN for a couple of months to build him up just to get him through to that wedding. So what are those family goals and how can we help achieve them? Palliative care plans look at 4 areas: physical, psychological, social, and spiritual needs, and we use an interdisciplinary approach. Our focus is to educate and support the patient and the family. Again, this can be across all settings, and then bereavement and grief support for families once the patients die. This next slide is a really cool picture because this kind of is a great visual of where palliative care fits in. So in the beginning, under disease-modifying treatment, you're diagnosed with cancer, there's a lot of time and effort and money spent on, you know, staging you and chemotherapy and radiation and maybe surgery and a different chemo, a lot of time. But as time goes on, there's less and less treatments available. And then the palliative care piece becomes bigger. There's more symptoms, there's more nausea, there's more weight loss, there's more fatigue, there's more depression. You know, the families are getting stressed out. And who's really dealing with that? And that's where palliative care comes in. And then there comes a point when hospice care is appropriate, and then the patient dies. So the next slide looks at those 4 areas that I told you that we address. And we're just going to flip quickly to the next slide, which kind of breaks them down. So when I say we're addressing the physical needs, we're looking at their nausea, their appetite, constipation, pain, fatigue. Are they sleeping? Are they functional? When we look at psychological aspects, we're looking at, are they anxious? Are they depressed? Are they fearful? Are they agitated? Social looks at, you know, are they worried about the financial burden? You know, nobody wants to be dependent. One of the big things that people don't want at end of life is they don't want to be dependent on others. Are they afraid that their families are not going to survive financially once they're gone? Especially this is true for younger families where, you know, maybe they have young kids dying of cancer, the mother doesn't work, the husband is the breadwinner, and now he's dying of cancer. You know, sexual function, we pay no attention to that at end of life, especially with our younger population. And then the last category is spiritual. You know, how do we address their spiritual needs? Did we get the rabbi to come in? Did we get last rites for them? Do they want to receive communion? Have we addressed those spiritual needs? So when you're doing a palliative care plan, you're basically looking at those 4 areas. Next slide. So the benefits of palliative care is improved symptom management, improved communication, improved quality of care by letting families make informed decisions. When I meet with a family, I say to them, every decision you make is based on the risk and the benefit of what this will do. What is the risk of TPN? What is the benefit of TPN? And let's make a decision. Palliative care improves patient and family satisfaction. We help obtaining DNR orders, and we help transition to home, to hospice, and to long-term care. Nurses are the constant. We need to become educated and educate others. Next slide, the consequences of a late referral to palliative care. Care in the ICU is associated with a 5 times greater risk of post-traumatic stress for the family. Care in the hospital is associated with an 8.8 increase in family risk of prolonged grief. And the statistics, the resources are there for you for that. In addition to pain management and symptom management, we also focus on their goals of end of life. You know, do they have an advance directive? Next slide. Do they have a post form? If they're in New York, do they have a most form? Have they completed the 5 wishes? Do they have an advance directive? Do they have an out-of-hospital DNR? Have they assigned a healthcare proxy? These are things that we talk about with families because we want to make sure that patients discuss this while they're able to do so. And I say to them, there's going to be a time where you're not going to be able to do this. The next slide looks at how do we implement palliative care in home care. You know, what we do when we go out into the home is we review the chart, or the nurse reviews the chart to identify if the patient's appropriate. The nurse will discuss with the family that they'd like to have a consult. If the family agrees, the palliative APN is contacted. The APN schedules a home visit within the week. The APN will collaborate with their primary doctor. The APN will complete the post form or the most form, and a copy of the full note will be sent to the home care agency and to the physician. The benefits for a home care agency: we manage the symptoms at home, we keep the patient out of the hospital, we increase the patient family satisfaction, we control costs by keeping the patient at home, and we assist with advanced care planning. All of the palliative care visits are covered under Medicare, so we just bill their insurance company. We also provide palliative care education. You know, your home health aides are the ones that are with the families 24/7. You know, well, not 24, some 24/7, but you know, they spend more time with the families in home care. So, do they know how to handle it? Do they know how to talk to a family when the patient says, "I think I'm going to die," or when the family says, "You know, I think my father's dying." You know, do they know what to say? You know, is their answer, "Okay, what would you like for breakfast?" You know, or do they really, you know, can they understand that how they should facilitate that conversation? And that because a person says, "I think I'm going to die," the answer isn't, "Oh, no, you're not," you know, when really they are. And that's their patient's way of saying, "I need to talk about this. I'm afraid. I don't know what's happening. I have questions." Maybe there's nurse training that you need to help nurses identify which patients are appropriate. You know, I've done community trainings and family trainings, you know, to help people understand. So if, you know, there are groups of families that need to be educated, that's something we do. And that's it in a nutshell. Any questions?
Oh, friend, this is Adina. That was that was a great overview of palliative care. I have a question for you, and I know we're a little bit past 9, so we're going to wrap up. My question for you is, though, I know you mentioned that there was a website because we have folks, you know, from Florida and New York and otherwise who are going to be, you know, pursuing this as an option for their clients. And I was wondering where that website was that we can direct people to so that they could find out about resources in their communities.
Well, you know, I would basically, you can just, you know, as far as specific resources, you're going to have to kind of identify, you know, what the hospitals have. You can look at CAPC. CAPC is the Center for the Advancement of Palliative Care, and they keep data on all hospitals with palliative care programs, so that would be a good place to start. You know, there's not really a lot of outpatient palliative care stuff. I mean, in New Jersey, you know, some of the hospitals are starting to look at, some of the hospices and hospitals are starting to look at outpatient palliative care, but there's really not a lot of people doing that, you know, in New Jersey, and there's not really a lot of people doing it out there. It's still really new getting into long-term, getting into home care. So, you know, if anybody has any questions, that's why I left my number on the first slide. You know, they can certainly talk to me, and I'll be happy to give them, you know, any resources that I might have specifically in that area. People that I know, you know, through my organizations are doing palliative care in their areas.
Okay, that's very helpful. Yeah, we'll definitely share your contact info. What about what about you have a nurse practitioner, a couple of nurse practitioners that we work with, and they usually refer to the hospice, like you said, to the palliative care, because that seems to be what the programs are here. It just is kind of all encompassed together. So would these nurse practitioners need to have, I guess, specific training in order to start treating those clients for us in the home?
Right. You know, there's, you know, I'm certified as an advanced practice nurse in hospice and palliative care and also in pain management. You know, so it has to be somebody that's comfortable doing that. Where are you located?
Sorry?
Where are you located?
Oh, in South Florida. We are in Palm Beach, Broward, and Dade County.
Okay.
But every time, you know, when I go to my healthcare council meetings or I go to any of these groups, it's always encompassed. Like hospice is usually the one that always brings in the palliative care speaker. They have their team that does palliative care, and then once the patient kind of rolled into hospice, and they kind of take them that way. So it's like a one.
Right, sure. And that's why hospices have decided to implement palliative care programs, because they know that a lot of people don't want hospice and aren't ready for hospice. So, you know, by doing the palliative care piece, then when the patients are ready to transition, they're already their patients and they don't lose them. So that's, you know, a lot of reasons why the hospices are now incorporating palliative care.
That makes sense. Thank you.
You're welcome.
Fran, thank you so much. I really appreciate your time and presentation today, and we will definitely share your contact info for folks to get in touch with you if they have questions. And, and thanks again, and thanks everybody for calling in. Hope you have a great weekend. Thank you, Adina.
All right, bye.